Let's recognize the presentation first. That's how you catch preterm labor. Preterm labor presents in a pregnant woman before 37 weeks of gestation who comes in complaining of uterine contractions. These contractions are regular, consistent, and they increase in intensity, duration, and frequency. And this detail matters, because if the contractions are irregular, this is not preterm labor. That would be false labor or Braxton-Hicks contractions. The second key feature is the cervix. In true preterm labor, there is cervical dilatation, usually more than 3 centimeters. So you can summarize the presentation with 2 C's: contractions with the proper characteristics and cervical dilatation. Once you see these two together, this is preterm labor, and this patient must be hospitalized to start management. The main goal in the management of preterm labor is inhibition of labor, to buy time and allow fetal maturation. Management depends on gestational age, and this is very important for exams. If she is below 32 weeks, we give full preterm labor management: betamethasone for fetal lung maturity, tocolytics to stop uterine contractions, magnesium sulfate as a neuroprotective agent, penicillin if GBS is positive or the status is unknown. Between 32 and 33 weeks, management is the same except for magnesium sulfate. Magnesium sulfate is only indicated in severe prematurity, so remember this point well. Between 34 and 36 weeks, management becomes more limited. Betamethasone may still be given. Penicillin only if indicated. After starting inhibition of labor, the response determines the next step. If labor is successfully inhibited, the patient is discharged and followed up in the outpatient clinic until delivery. If there is no improvement, we proceed to termination of pregnancy. In many cases, we can avoid all of this by preventing preterm labor. So how do we do that? This takes us to the next part. Prevention is especially important in high-risk patients. These include women with a previous history of preterm labor, prior cervical surgery, or multifetal pregnancy. These patients need special management aimed at preventing preterm labor before it even starts. We begin with progesterone therapy. After that, patients undergo transvaginal ultrasound to measure cervical length. If the cervix is short, the next step is cervical cerclage, followed by serial transvaginal ultrasounds until 24 weeks of gestation. If the cervical length is normal, no intervention is needed. Only serial screening with transvaginal ultrasound up to 24 weeks. And now, let's apply all of this clinically. Let's move on to the cases. Let's look at this case. The patient is at 28 weeks of gestation with 3 centimeters cervical dilation, 90% effacement, and regular contractions every 5 minutes. Here, the double C is achieved: regular contractions and cervical dilation. This confirms that we are facing a case of preterm labor. Since she is below 32 weeks, she requires full preterm labor management, just as we outlined in the management diagram. She has already received betamethasone and indomethacin as a tocolytic. The next steps are magnesium sulfate for neuroprotection, penicillin if indicated for GBS or unknown infection. Based on this, the correct answer is A. The patient is at 16 weeks of gestation, in her second trimester, with a history of previous cervical surgery for neoplasm. Referring back to our prevention diagram, she is clearly high risk for preterm labor. According to the prevention protocol, she should receive progesterone injections, undergo transvaginal ultrasound to measure cervical length. Based on this, the correct answer is F. Here's a tricky one. The patient is at 35 weeks of gestation. At first, she reports 3 to 5 contractions every hour and has a history of preterm labor, and was receiving progesterone injections. At first glance, you might think, rapidly, this is preterm labor, and jump to management options. This is exactly the tricky part of the case. But if we look closer, her cervix is still closed. Tonometer shows irregular contractions. These are exactly the characteristics we discussed for false labor: irregular, non-progressive contractions. So despite her risk factors, this is not preterm labor. Therefore, no active preterm labor management is indicated, And the correct answer is F. Reassure and discharge the patient.